I currently practice, but at the same time I try to study several problems, clinical and also pathophysiological problems linked to portal hypertension. Indeed, the majority of my patients are patients with cirrhosis and complication of portal hypertension. So the focus of my research is mainly trying to resolve the clinical problems associated with this disease, and at the same time I would like to go more in depth of the biology that we have behind this disease. My research is focused on clinical and pathophysiological aspects associated with cirrhosis and portal hypertension. Probably it's better to say associated with portal hypertension. We know that this disorder is due to cirrhosis in the majority of cases, but it can be also due to other liver disease, for example vascular liver diseases such as portal vein thrombosis or Budd-Chiari syndrome, but also in the last year we are paying a lot of attention to the idiopathic non-cirrhotic portal hypertension, and my research is mainly targeted on this kind of disorders. At the same time, I'm trying to understand if the hemostatic imbalance that has been showed in patients with portal hypertension and cirrhosis in the specific can have a pathophysiological impact on the natural history of cirrhosis. Probably it is the most important challenge that I'm trying to manage during these last years, and we will see in the future what will be our results in this field. Yeah. I have 3 posters. For 2 of them I'm the first author. The first one is related with a clinical problem, that is the safety, the risk-benefit ratio of anticoagulants in patients with portal vein thrombosis and cirrhosis. During last month, probably it is correct to say that we have a bit changed our mind about the treatment of portal vein thrombosis in cirrhosis, because there is an important paper published by the French group that demonstrated the patient with portal vein thrombosis in cirrhosis can have a very high resolution rate without treatment. It is important, I think, starting understanding which is the real subset of patients with cirrhosis that worth a treatment with anticoagulation, just to improve the benefit-risk ratio of treatment. I think that their results are in line with our concerns, because we started this study to understand what is the best strategy to improve the benefit-risk ratio of anticoagulation. It means that probably not all patients with cirrhosis need anticoagulation, and it is necessary discriminated patients for the risk of bleeding anticoagulation, and probably we can improve the strategy of treatment by considering also these results. The abstract that I'm presenting at this meeting is aimed at describing the bleeding risk associated with anticoagulation, and we compare 3 cohorts of patients. The index cohort is the cohort of patients with cirrhosis and portal vein thrombosis that were treated with anticoagulants, and we compare this cohort with another one of patients that received anticoagulation but did not have cirrhosis, just to understand if cirrhosis per se is an additional risk of bleeding under anticoagulation. Just to adjust the intrinsic risk of the cirrhotic cohort for the bleeding related to portal hypertension, we compared our index cohort with another one that included patients with cirrhosis that were not treated with anticoagulation. And finally, we had, I think, interesting results because we showed that patients with cirrhosis that receive anticoagulation have an increasing risk of bleeding related not with portal hypertension, but related with minor bleedings. And these minor bleedings probably can be predicted by some variables. Actually, in our analysis, we find out that the bleeding risk was associated with the presence or not of hepatocellular carcinoma, with the value of albumin and the sex. I think we cannot draw definitive conclusion on the risk of bleeding anticoagulation, but probably the best important message is that we need a tailored approach taking into account the variables that are associated with this risk. I cannot predict that. What I can say is that in a meeting such as the EASL, we can meet all together and starting a collaborative work that I'm sure it is the right strategy to resolve this kind of question. I think that probably one of the most important topics that I have seen that are perceived by the scientific community as important task for the future is trying to understand better the diagnosis and the clinical problems associated with idiopathic non-cirrhotic portal hypertension. That is also a field of interest for my research activity. I think we are trying to put a bit of order in this field because, for example, in the past, this disorder was called in very different ways. We have several names, probably for the same disease. And we have to start from these simple things, that is giving the same name to the same disease, just to improve our scientific activity and probably just to start with the right description of our clinical cases and to allow our results to be comparable between groups. It is a key point for scientists, physicians, I think, and we will see in the future, I think, very important new results in this topic. Yeah.